Okay, we are doing great. I'm joined today by Dr. Kevin Carmichael and Dr. Joel Terriquez. They are going to give you a little bit of information on who they are and why they're here to talk about the Mpox updates for Arizona today. So, Dr. Carmichael and Dr. Terriquez, I'm turning it over to you.
Great. I'm Kevin Carmichael. I'm a family practitioner by training, but I work as a consultant for the ADHS around sexual health, which includes HIV, PEP, PrEP, things like that. And then Mpox, when we started in 2022, I was drawn into that and I've spent a lot of work on that. Joel?
Yeah, so first of all, thank you everyone for taking the time of the day to join us on this really important topic of Mpox. We're going to be focusing on Clade 1 and 1B. I'm Joel Terriquez. I'm the medical director for the Bureau of Infectious Disease and the Bureau of Immunizations with the Arizona Department of Health Services. We'll just go ahead and get started. And speaking of Mpox, first question that usually comes next, Isabel, that usually comes up is where's this Mpox coming from? What's this business about Mpox? So Mpox is not new. We've known about Mpox for years. First case of, and just going a little bit through history, I promise that I'm not gonna bore you to death with the history of Mpox. First case of Mpox was initially identified in some monkeys that were used for laboratory purposes in Denmark, 1958. Ever since, we've seen sporadic cases of Mpox. 1970, first case of Mpox in humans that was identified in Congo. By 1980, we were already noticing some sporadic cases, up to 100, 500 cases that continue escalating up to a bigger outbreak in 1996 in Congo. By 2017, sorry about the typo there was a bigger outbreak in Nigeria where probably around 100 cases were identified outside of that Congo area in Nigeria. 2018, this became an interest for the rest of the world as there were international sporadic cases seen in other countries of the world. By 2022, that's when the WHO basically announced that this was a public health emergency of international concern, especially focusing on Clade 2B. We know that down the line that kind of cooled down as we saw several cases, significant amount of cases, even in the United States. And then most recently, we're seeing cases due to Clade 1. We will continue talking about this as we go. Next. So we know that Mpox, by now, we've seen cases of Mpox in several areas of the world. Again, in 2022, we saw worldwide cases of Clade 2B mostly. There was a big peak towards the end of 2022. Ever since now, significantly decreasing. Now the concern or the number of cases is on the lower side. Since January 2023, Congo has reported over 27,000 suspect Mpox cases and more than 1,300 deaths. This mostly associated with Clade 1 of Mpox. We know that Clade 1 happens to be endemic for Congo. We know that this Clade 1 has spread to some contiguous countries surrounding Congo, including Central African Republic, Republic of Congo, Rwanda, Uganda, and other travel-associated cases in Kenya. Clade 1, we know it's divided in a couple of different subclades, 1A, which happens to be endemic, and 1B, which is the one recent concern that has emerged in 2023. Most recently, over the last month or so, we have seen cases of that Clade 1 outside of Congo, either the recent case in Sweden or the most recent case in Thailand, which obviously raised significant concern worldwide. Next.
So I'm going to talk a little bit about Clade 2B, which was which is continuing to be a problem for us here in Arizona and around the world. Really, in some ways, we're going to talk about Clade 1, but there really remains a Clade 2B epidemic as well. So the Clade 2B epidemic started in early 2022. It peaked in August And since that peak, there's been low-level transmission in the United States throughout. Most of the new cases are in people that are not vaccinated, but not all of them. The Clade IIb epidemic was driven by sexual contact. About 85% of people with Clade IIb identified as men who had sex with men. Currently, as of today, in Arizona, we're approaching 60 infections for 2024, compared with only 17 in 2023. Next slide. This is actually from the Mpox dashboard that's on the ADH website. And you can sort of see that back in 2022, there was this huge spike, fell off rapidly. And then we really had nothing for most of 2023. But if you start looking after March, we've had a sort of a consistent, steady number of cases each week. So some questions about why that spike happened. Why did it come on so fast? Why did it go away so quickly? There's probably several reasons for it. A lot of people point towards vaccination. However, the drop off really happened so quickly that it probably had as much to do with changes in behavior as it did with vaccination. So I think part of the reason I think we're seeing an increase now is that people, 2022 is now a couple of years ago, and people who had made changes in behavior are now, going back to things they were doing before, and putting that at risk. Again, this is Clade IIb, and that's the only clade that we have in the United States at this time. Next slide. Joel?
Yeah. So, as you guys know, the current international concern is Clade I, Clade Ib. By August 14th this year, 2024, the WHO declared Mpox as a public health emergency of international concern. We know that Mpox in general, it's a zoonotic disease. We know that's usually spread by close contact between animals to humans or human to human. Clade Ia outbreaks in Africa are usually a combination of a couple of things, either animal to human interactions, household transmission, which we have seen also with Clade II, and sexual contact. I have to continue highlighting that we have not seen any Clade I cases in North America. Those are mostly localized in Africa, with a couple of cases that have been identified outside of that area in Sweden and Thailand. We know that the demographics of Clade I, it happens to be extremely variable. It really depends on multiple factors of the community, as well as other variables associated with the virus itself. We know that there has been around 20,000 suspected Clade I Mpox cases, and suspected, again, 975 deaths associated with Clade Ia Mpox. And this is just in that time frame between January and 2023 and April 2024. Interestingly, most of those cases, the vast majority of those cases, are in children younger than 15 years of age. Next. So we know that there has been some outbreaks involving Clade Ib, especially in Africa, and those have been highly associated with sexual contact. A majority of those cases have been reported in heterosexual individuals. Around half of those cases have been reported in women, and with a majority proportion of those being sex workers. Next. Some questions have come up regarding virulence, or different virulence when we compared Clade I to Clade II. We know that mortality happens to be, for multiple reasons, higher in Clade I compared to Clade II. Clade I case fatality rate has been reported in the past at somewhere between 1 and 10%. Recent data has reported that this might be lower, down to 1.7%, but in average, the mortality rate in Congo is reported at 3.6%. When it comes to Clade II, case fatality rate happens to be lower, reported between 0.1 and 4%. There has been some evidence in animal models that there might be some rapid spread of this virus, or that infection associated with Clade 2B, Clade 1 may carry higher viral loads and more rapid spread, which would be associated with this higher mortality and higher transmission. Another interesting factor that we need to consider when it comes to higher mortality would be lack of access to care. So it would be interesting for us to know if this mortality that we're seeing in this particular area of the world that happens to be higher with Clade 1 when compared to Clade 2 could be associated with lack of access to care. So that's a question that keeps coming up. I'm not really sure that we have the answer to that yet. More studies to come on that. There has been virologically, there has been reports that Clade 1b, which happens to be slightly less virulent than 1a, may have a large deletion in the genome, which is also found, that specific deletion is also found in Clade 2, and that deletion is usually associated with lower virulence. So that's an interesting situation to consider and to factor in the fact that this infection with Clade 2 and Clade 1a may be of lower virulence. We know, though, that persons with immune compromise will remain at higher risk from all clades of Mpox. So even if you happen to be a transplant patient, an individual with uncontrolled HIV, no matter what infection you get related to Mpox, you may carry a higher mortality or higher risk for poor outcomes. Next. So we can't really have an Mpox discussion without talking about the rash. We need to talk about how things would look like. We know that incubation period can be variable, usually around 5-7 days. Constitutional symptoms, classically for any viral infection, including headaches, fevers, sore throat, swollen lymph nodes, regional lymph nodes, depending on the area of the infection, rectal pain if we're dealing with pelvic infection, anogenital lesions. We know that this rash will have the same progression, and it will start with macules, papules, progressing to vesicles until it ends up being crusting lesions. So as you can see on those pictures, those are actual patients that we have cared for here in Arizona. We are seeing all types of different lesions, whether that means pustules or vesicular lesions, as we're seeing in that hand on the top left. We have seen some other lesions that progress into more crustiness healing lesions, as we can see in the bottom right there image. So multiple different types of lesions. We need to just remember that they're usually in the same stage and that they will have this progression from macules to papules, vesicles, and then crusting lesions. One of the classic findings, though, is that most of these lesions, especially those pustules, will have some degree of umbilication at the center, which gives the classic pox appearance to those lesions. I personally call them Cheerios. They look like Cheerios. And so if you're eating Cheerios, my apologies. But that's kind of how they look like in my mind. So next, please.
Yeah, so I was going to talk a little bit about testing for Mpox, because obviously we still have an ongoing outbreak here of Clade 2b, and I'm pretty convinced that we're actually missing cases across the state and across the country because people aren't thinking about it and not testing for it. Testing is fairly simple. The first thing is to have a high index of suspicion. So if someone has had a sexual exposure, begins to develop painful rash or other symptoms, dysuria, pharyngitis, or proctitis, do think about Mpox. If people have ulcer disease in a region, we need to think about syphilis, herpes simplex as well. I also think that in these situations, HIV testing is probably worth doing, but a clinical suspicion is important. To test, you just need to use a swab, not a cotton swab, but a synthetic swab, and just swab the lesion. This will be providing these slides. It's easy. You do not need to unroof the lesion. There have been healthcare workers who have gotten Mpox by a needle stick after trying to unroof a lesion. The lesion has lots and lots and lots of virus on it. Just simply swab the lesion, rotate the swab again, and put it in viral culture media, refrigerate, and send off to the lab. We generally recommend swabbing at least 2 different sites, 2 different lesions. And again, it's easily done, and I think we need to do more testing rather than less, so have a high index of suspicion. Next slide. So when we talk about Clade I, what are the concerns for the United States and for Arizona? Right now, the attention is focused on this worldwide epidemic that is focused primarily on Central Africa. Again, I'll highlight, as we've said before, there are no Clade I cases in the United States at this time. The CDC feels that the risk is fairly low. There's not a lot of commercial flights from the Democratic Republic of Congo and those countries to the United States. But this might change if this epidemic continues to grow in Africa. Most of the people that I've talked to around the country, I think we all feel that it's inevitable that we will get Clade I here. But hopefully we can identify it and prevent it from spreading. Okay, but it does, I want everyone to be prepared that you're going to read in the paper sometime there's going to be a Clade I infection in the United States. The best protection would be to be vaccinated with Jynneos. Now, we know that the Jynneos vaccine is not perfect at preventing infection, but it clearly moderates the infection if someone is infected. You can also protect yourself from close contact. The CDC says avoid contact with wild or dead animals if you're in an area where Mpox occurs naturally, which it doesn't here. There have been cases of household transmission either through contact or possibly through bedding or other materials. But it's really probably not spread that easily. My opinion, and again, it's my opinion at this time, is that the issue of virulence that Dr. Terriquez just spoke about really is complicated. We have essentially three epidemics going on right now. We have Clade IIb, which is around the world. We have Clade Ia and Clade Ib in Central Africa. And there's just huge differences between the healthcare systems, nutritional status, lots of things going on. And so I don't think that we can assume that the mortality that is seen in Central Africa, or the severity of disease seen in Central Africa, is going to translate to the United States. But again, it's still very much an unanswered question. There was an article I read yesterday in the Lancet that suggests that all clades have a similar virulence, but again, the data just isn't really there to know. So I think we need to be concerned, we need to be alert, but I don't think we need to necessarily be panicked at this time. Next slide. So again, vaccination is key. And currently we have Jynneos available. Jynneos is a vaccine that was developed for smallpox. It's a replication incompetent viral vaccine, so it cannot cause disease. And it's currently indicated for people who were in the high risk group for Clade IIb, gay, bisexual men and other men who have sex with men, transgender, non-binary people who've had a STD in the past 6 months, or more than one sexual partner, sex at a commercial venue, or sex associated with a large public event where Mpox transmission is occurring, or the sexual partners of those people. The one complication now with Clade Ib sort of emerging and people becoming concerned is that recently Jynneos, which we had been getting for free from the Strategic National Stockpile, that's medicines and vaccines that were stored in the case of a smallpox outbreak, a bioterrorism event. We were getting these vaccines for free, but now they're commercialized. And there's a period of time where it takes to get from, how people can get a commercialized vaccine. The vaccine is not inexpensive. Insurances should cover it for the appropriate people, but insurances are taking a little time to sort of get that coverage in place. The vaccine is now available at Walgreens and CVS, I'm told. I actually signed up for it and then canceled it at CVS to see if it could actually happen. So it is available to people with insurance. Uninsured people, a little bit tougher right now. So that's for pre-exposure prevention. And then the next slide talks about post-exposure prevention. And in people who have been exposed to an Mpox case, if you can vaccinate them, ideally within 4 days, but up to 14 days after exposure, you can probably protect them against either infection at all, or certainly moderate the infection they get. Again, the big problem is you have to get to people fairly quickly after their exposure, and that doesn't always happen. Currently, people that have been vaccinated, have had a full vaccine, a full course of 2 vaccines, do not need an additional booster. That's not recommended this time. People that had Mpox are felt to be well protected, and do not need vaccination at all. Most of the county health departments, I know Maricopa County has Mpox vaccine available. I believe Pima County still does. And other counties' health departments will hopefully be getting access to vaccine. So that's probably the first place to look, although insured patients do have other options. Next slide.
So as Dr. Carmichael was mentioning, the most important approach for the management and prevention of Mpox will always be vaccination. So we highly recommend those individuals at risk to get their vaccination, knowingly that we have also limited amounts of the alternative, which would be actual treatment for Mpox or an antiviral medication called tecovirimat. This medication has not been FDA approved specifically for Mpox, has been approved, has been utilized in the past for the treatment of smallpox. We also know that individuals with an intact immune system, they should not have any issues because most viral infections will be self-limiting. So supportive care, pain control should be sufficient for those individuals that have a normal immune system. With some exceptions, obviously, if for whatever reason your patient happens to be immunocompromised due to recent history of cancer, chemotherapy, HIV that is uncontrolled, they may be at risk for severe infection or disseminated infection. We also know that some individuals that have a chronic skin condition such as eczema may also be at higher risk for complications. What are we talking about whenever we're talking about complications? Whether that means ocular infection, neurological complications, myopericarditis, all of those are possibilities, or even severe infection causing mucosal involvement that will cause other complications associated with that. So scarring, among other things. So there are several different antiviral medications that could potentially be used to treat Mpox. The most popular one being TPOXX or tecovirimat. Others that are worth mentioning would include cidofovir, brincidofovir, which may not be as I'm not going to say studied, but there may be less experience with these medications when compared to tecovirimat. Even if we were to utilize tecovirimat, we know that, or I should say, we are still uncertain if it will be effective enough to treat this infection or to limit the amount of lesions or to stop the progression of infection. We know that it may be just as good as supportive care. There was this interesting randomized controlled trial that happened in Congo where they basically randomized 597 confirmed cases, either to TPOXX or placebo, which include basically supportive care, hydration, etc. They hospitalized those patients for 14 days. And basically, they identified that TPOXX or tecovirimat did not really decrease the duration of those skin lesions. Also, interestingly, they found that the actual mortality associated with Clade I was lower than the previously reported, down to 1.7% when we knew or we were concerned about that 1 to 10% mortality with Clade I. So that was an interesting finding. So just to highlight again, tecovirimat in that specific randomized control trial did not reduce the duration of Mpox lesions among those children or adults that were confirmed cases. Next slide, please. And just if you happen to be remotely interested in the science behind TPOXX, I'm not gonna obviously go extremely scientific on this. I just want to make sure that at least there's a little bit of understanding of where TPOXX works. So virus, which is top left, we have that enveloped extracellular virus that will be attached to our human cell. It will be incorporated, transported through microtubules from the surface of the cell down to the perinuclear area. Usually, most pox viruses are large enough that they will not replicate inside of the nucleus. So they will have perinuclear cytoplasmic replication. So once this, the DNA of this virus is used as a template for replication, then that immature virus will be transported to the Golgi apparatus where it will be assembled and then kind of released into a mature extracellular enveloped virus. So tecovirimat will impact that release from the Golgi apparatus, will block that final conformation of the virus before release. So that's where tecovirimat or TPOXX will act. So the virus will not end up being that final mature virus that will be released into the environment. So again, just to highlight this, TPOXX or tecovirimat will not prevent infection. Patient will still get infected. So the most value that we're gonna have, or that we're gonna, the most value that we're gonna find for our patients would be to provide them with vaccination. Next slide.
Yeah, up, back. We're going crazy. There we go.
There you go.
So this is just a slide again. We'll be sending this out. This is just a list of resources from both ADHS and the CDC, and of course DISH-AZ, which is Detailing for Improved Sexual Health. We're able to do answer people's questions individually or do talks for clinics or anything else. Basically, that's our presentation, and we really wanted to really have mostly time for questions. I looked at the attendees. The attendees are very distinguished here, so I'm happy to have people correct some of the things we may have said that aren't correct or add further information. I will mention one thing. Dr. Terriquez just mentioned that one trial in Uganda in the DRC did not show efficacy of tecovirimat. There is a trial called STOMP in the United States that is enrolling people with Clade IIb or currently with Mpox. Its enrollment has been a little slow. They're not quite up to the number that they need to get an answer, but there are several trials around the world looking at tecovirimat for Mpox, but that African trial was certainly was certainly interesting, if that's the correct adjective. Next slide, I think, is a thank you for everyone. And the next slide says questions. So Isabel, do you want to?
Absolutely. I am here and I'm going to hit the end of our recording.